Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and our program part of the Digital Anatomic Pathology Academy, a joint venture with Digital Pathology Association and Path Presenter. Our case today comes from the files of the University of Oklahoma Health Sciences Center. And in our Adventures in GYN Pathology series, it's a 52-year-old woman who has noted several months of abnormal postmenopausal bleeding. So a curettage is done, and the curettage doesn't show any endometrial proliferation, but does show a fair number of lymphocytes within the stroma of the endometrium. And when we think about that, you're sort of faced with an interesting differential. Certainly at postmenopausal age, one would not think of chronic endometritis in the usual sense. And no plasma cells were observed in the curettage. So that doesn't really fit very well there. Certainly incidental lymphoid aggregates can occasionally be seen, although again, they are quite unusual in the endometrium. Lymphoma enters into the differential diagnosis, although usually it's large cell lymphoma, more obviously malignant. And then of course you have various small blue cell tumors that may masquerade as lymphocytes, everything of course from neuroblastoma to Ewing sarcoma and so forth. And then, of course, it could be something else altogether. Nevertheless, because of her age category and other low risk factors, she underwent a hysterectomy, and we received the hysterectomy specimen. As we can see at low power, we do have something of an infiltrative appearance centered around the endometrium, with no evidence of involvement of the deeper portions of the uterus. And looking more closely here, we see that, she has some intact, widely spaced endometrial glands here, and then this very blue infiltrate that actually seems to be sparing the endometrial glands and most of the endometrial stroma. So this is a fairly good appearance. Also, we note that there is some sense of a little clustering around the vasculature. Here we see some of these vessels here associated with this. Looking at these things at higher magnification, we see that they seem to be fairly uniform, small blue cells, a little bit of sort of onion skin appearance. No real evidence of large cells, no germinal center formation is noted, although there is this sense of nodularity to it associated with the vasculature that we can see here. And of course, fixation, a little bit suboptimal, things are separating apart here. But there is maybe a suggestion that there might be some follicular center cell differentiation here. So that certainly raises an interesting consideration. Looking at another section from this same case, we see again the same process, sort of a ragged interface between the endometrium and myometrium. But again, this interface is not one with very much glandular tissue involved. Although there are some glands here, but mostly this centered lymphoid type tissue, small blue cells with associated delicate vasculature within what would be considered the stromal compartment, I suppose, in this case. So this has the appearance of lymphoma, probably low grade based on the small lymphocytic size, lack of mitotic activity, and the perivasculocentric pattern. So we can ask ourselves, what do we know about possible lymphomas in the GYN tract? Well, first of all, you sort of have to think about things that are primary, occurring here as the presenting symptom, as opposed to those that occur when we already have a diagnosis of lymphoma from some other site. And when it's a primary lesion, these are most commonly seen in the cervix. They generally present as very early, low-stage tumors, stage 1 or 2. And most commonly, a diffuse large B cell is the most frequently encountered type. This perivascular localization is quite characteristic in the cervix, as we see here in the endometrium, but less so perhaps when it's more of the secondary type. And as I indicated, diffuse large B cells most frequently encounter type in primary lymphomas, Still most frequent in secondary type tumors, but other mixtures, follicular lymphoma, mantle zone, marginal zone lymphoma, and so forth can occur in secondary types. And these, of course, then, by virtue of being secondary, are usually stage 3 or 4. The other interesting difference is that most commonly, these tumors will tend to involve the corpus and cervix. Or if it's just one, it's much more evenly divided between the corpus and the cervix as opposed to the primary tumor. Now, although the outcomes vary with either one of these things, it's not uniformly poor. So this is not necessarily a death sentence. Well, of course, we did immunohistochemical studies with our stain or with our case. And as you can see here, this lights up the cells quite nicely. This is the CD20 stain indicating that this is a dominant B cell population. And if we do corresponding stain with CD10 to exclude or consider the possibility of a follicular type lymphoma, we see that while the endometrial stroma stains nicely with CD10, our lymphoid population is uniformly negative. And so I think with that, we probably can exclude most cases of follicular lymphoma. And of course, the other T cell marker, CD3, as was CD5, CD43, other markers we did in that realm, showed a mixture of cells, predominantly at the periphery of these more lymphoid areas. So just to review what's in the literature a little bit, as I mentioned, primary lymphomas most commonly seen in the cervix. Only one out of this case, this series, where 10 primary lymphomas of the lower uterine tract were evaluated was originating from the corpus. And as you see, again, diffuse large B cells, the most commonly found type. And survival is really quite good. No evidence of disease at 10 years, no evidence of disease at 5 years, alive after 4.5, 5 years, and so forth. So of those with follow-up, the majority are getting reasonably good survival. And with those that are secondary type tumors, we can see, again, the presenting symptoms usually are abnormal bleeding, occasionally mass or weight loss, but here mixed between the locations, corpus cervix, and so forth, more of a smattering of things, and a mixture of types, some follicular lymphomas, B cell SLL, probably the closest thing to our particular case in a couple of cases involving either the cervix or the corpus. So that's kind of the appraisal there. So our final sign-out diagnosis here for today is primary B-cell lymphoma of the uterus, low grade, not otherwise specified, probably small lymphocytic lymphoma. Of interest, this is a case where we have some follow-up. This patient later was found to have low-grade lymphoma involving other sites. And the patient is alive with no evidence of residual disease at more than 10 years follow-up. So certainly a good outcome in that situation. Well, thanks so much for joining us. We hope that if you like this case, that you'll subscribe so you'll catch future releases. And we always welcome your comments and encourage you to share it with colleagues or friends who may be interested in this topic. We are eager to receive your suggestions for new topics that should be covered, new vignettes of usual and unusual cases that you may be interested in. And until next time, thanks for joining us.